Hello, this is Dr. Heba Anis. I'm a board certified nutrition support pharmacist and I'm the Pharmacy Affairs General Supervisor at the Egyptian Health Authority, as well as an adjunct faculty at Misri University for Science and Technology. Also, I've been working as the Deputy Manager of the Clinical Nutrition Unit at the National Cancer Institute, Cairo, Egypt. Today, we'll be talking about a very important topic in which we will be addressing the importance of specialized nutrition for cancer care. Our learning objectives will be describing the prevalence of malnutrition in people living with cancer, describing the impact of malnutrition on the treatment outcome as well as the quality of life of the patients, describing the special role of nutrition in cancer treatment and recovery, as well as describing the use of high protein oral nutrition supplements. Also, we will identify cancer patients who may benefit from the nutritional support and ending by describing the pharmacist's role in referral and nutritional advice. Our content for today will cover several important aspects, starting with the prevalence of malnutrition, in which we will understand malnutrition in cancer and its rapid progression during treatment, going into the impact of malnutrition, in which how nutritional deterioration may affect the treatment adherence, side effects, and patients' quality of life. We will also emphasize on specialized nutrition support and what exact goals for maintaining the lean body mass and cancer anorexia cachexia syndrome could be achieved through specialized nutrition support. We will go through the oral nutrition supplements used in terms of definition, indication, and the use of high protein supplements to improve the clinical outcomes. We will also emphasize on some clinical recommendations, such as those offered by the European Society of Clinical Nutrition and Metabolism, the ISPN, and the European Society for Medical Oncology, the ESMO. We will also emphasize on the role of the pharmacist in navigating the patient journey through screening, counseling, and management different nutrition impact symptoms. So let's start by agreeing on a definition of malnutrition. Malnutrition is simply a state that could result from either a lack of the nutritional intake or an impairment in the uptake of the nutrients by the body. But the most important thing in malnutrition that it may lead to altered body composition in terms of decreased fat-free mass and body cell mass. Unfortunately, this may lead to drastic consequences such as diminished physical and mental function, which will cause an impairment in the clinical outcome from disease. So we need to highlight that we are concerned about malnutrition because at the end this will have very poor impact on the clinical outcomes of different disease states. But we have to agree on a definition of malnutrition. That's why we refer to that what was published by the GLIM or the Global Leadership Initiative on Malnutrition on 2021, in which they subclassified nutritional disorders and nutritional related conditions into undernutrition, sarcopenia or frailty, overweight or obesity, micronutrient abnormalities, or refeeding syndrome. And they did also a subclassification of undernutrition into three distinct categories. The first of which is disease related malnutrition with inflammation. The second is disease related malnutrition without inflammation. And finally, malnutrition or undernutrition that could happen without any coexisting disease but occurs mainly because of poor socioeconomic status or food deprivation. And they highlighted that cancer cachexia and other disease-specific types of cachexia are considered to be chronic disease-related malnutrition associated with inflammation. In accordance to the GLIM criteria, malnutrition could also be identified or diagnosed if the patient presents with one phenotypic criteria and one etiological criteria. The etiology could either be simply food deprivation or disease causing inflammation. And the phenotype could either be a decrease in the body weight, an impairment or a decrease in the body mass index, or a change in the body composition or the muscle mass of the patient. So it's enough only to have one phenotypic criteria and one etiological criteria to have a diagnosis of malnutrition. And in order to be able to diagnose undernutrition, two successive steps has to be undergone. The first of which is nutritionist screening, then followed by a general assessment of the patient. The nutritional screening could be done by using one of the published, agreed upon, validated screening tools. For example, Nutrition Risk Screening NRS 2002, the Mini Nutrition Assessment Short Mini Form, or the MUST or the Malnutrition Universal Screening Tool. Mostly any of these validating tools will measure factors such as the decrease in the body weight, the body mass index, the poor oral intake of the patient, and some of which may go even deeper, highlighting or correlating the effect of the disease on the nutritional status of the patient. And each of these tools ends up with a score, and there is a specific score. If calculated for the patient, it means that the patient is undernutrition. Of course, the weight and the scoring point may differ from one validated screening tool to the other. So, if we look deeper specifically into the cancer population, we will find that malnutrition is prevalent in patients with many types of cancer. However, the prevalence may vary from one type of cancer diagnosis to the other. And weight loss is considered to be the hallmark of malnutrition in any cancer patient. Actually, weight loss may be the initial presenting sign associated with cancer. So, at diagnosis, weight loss may be as common as 15 to 40% of cancer patients, and the percentage increases to be 40 to 80% at the stage of the cancer advances. The sad truth is that up to 20% of those cancer patients may die from malnutrition rather than dying from the cancer itself. We also have to highlight that deterioration of the nutritional status will happen during the journey of cancer treatment if left not diagnosed and if left not properly or adequately managed. So it's very important to identify malnutrition starting from cancer diagnosis. All guidelines have agreed that nutrition risk screening must be done once a confirmative diagnosis of cancer has been established, and that nutrition screening is not only a one-time job, but patients has to be rescreened at predetermined time interval according to their risk of malnutrition. We also have to highlight that the prevalence of malnutrition may slightly vary according to which validating tool has been used for nutrition screening. As mentioned earlier, those nutrition screening tools give different scoring point of different strength for different points of assessment of the nutritional status and impact of disease on nutrition. We also have to know that malnutrition risk depends on many factors, such as the tumor biology, such as the specific cancer type and the specific cancer stage, the used treatment modality in this specific cancer, the clinical condition of the patient, and other existing patient risk factors. What causes malnutrition in cancer patient? Actually, malnutrition in cancer is multifactorial. It could be because, or actually, it is an intricate of different factors, some of which are related to the treatment of self, some of which are related to the patient-related factors, and some other factors are related to the cancer cachexia pathophysiology. In terms of the factors related to the patient, the physical activity level, the clinical condition, the presence of other comorbidities, and the nutrition status prior to a cancer diagnosis. The treatment modality, which could be systemic treatment such as traditional chemotherapy or new biological therapies, or it could be local therapy such as surgery or radiotherapy. All of those multimodal treatment approaches may be associated with different nutrition impact symptoms that may affect the nutritional intake or the nutritional uptake by the body. In terms of the cancer anorexia cachexia syndrome and its pathophysiology, Cancer is that type of disease which is associated with chronic inflammation, and that chronic inflammation may lead to alterations on the different metabolic pathways in the body, leading to increased proteolysis, increased lipolysis, glucose intolerance, increased glucose turnover. Not only this, but other CNS controlled factors such as controlling the appetite, the smell, the taste, the anorexia, that all at the end affect the nutritional intake of the patient. So the causes of malnutrition in cancer are multifactorial. That's why we very much highlight on identification of the nutritional impact symptoms that may lead to malnutrition. It has been well known now that malnutrition in cancer patients is associated with many negative outcomes that affect both all of the adherence to the treatment protocol, the severity of the associated treatment side effects, the response to the treatment itself, the length of hospital stay, and the quality of life. And of course, all of those factors will be translated into an economic burden. We emphasized earlier on the importance of nutritional screening at cancer diagnosis. Nutritional screening is also important in order to identify the stage of cancer cachexia. Cancer cachexia is a multifactorial syndrome which is associated with a decrease in the uh, skeletal body mass composition, whether it is associated or not associated with fat loss. It has several dearrangements that cannot be completely reversed with traditional nutritional support, and unfortunately is associated with very poor clinical outcome of the patient. So screening for weight loss, body mass index, body composition are very important in order to identify what is the stage of cancer cachexia, which could either be pre-cachexia, cachexia, or refractory cachexia, all of which has its distinct hallmarks and of course have a different management pathway. So patients who are pre-cachectic usually present with a weight loss less than 5%. The metabolic changes have already started because of the cancer diagnosis. Patients usually present with anorexia and some altered food intake, while cachectic patients are identified by either having a weight loss greater than 5% or a weight loss as low as greater than 2% associated with either a body mass index less than 20 or a weight loss of greater than 2% associated with sarcopenia. Actually, sarcopenia in the cancer patient may start even before the decline in the body weight of the patient, specifically in obese patients who are said to have sarcopenic obesity. Sarcopenia is a state in the decline in the skeletal muscle uh, mass associated with a decline in the skeletal muscle strength. Also, in the cachectic phase, patient may have reduced food intake and, of course, systemic inflammation. While the worst stage of cancer anorexia cachexia syndrome is the refractory cachexia, and usually those are the terminal patients, patients who have not shown any response to the different lines of cancer treatment. And we say that those patients have a very low performance score. They have an expected survival of less than 3 months. They have variable degree of metabolic derangements, and the nutrition intervention in those patients, unfortunately, cannot have any positive clinical outcome. In terms of the intervention that will be done at different stages of the cancer cachexia, in the pre-cachectic phase, we have to monitor the patient closely to guard against any further weight loss. We have to aim to restore the lost weight if possible, and also to undergo all preventive strategies in order to prevent any decline in the nutritional status. While in the cachectic phase, it's actually a multimodal management approach that does not only involve the nutritional management, but also involves psychological, psychiatric management of any distressing factors such as pain, encouraging the physical activity of the patient, encouraging proper sleep patterns. And in terms of the nutritional intervention, it has to be multifactorial nutritional management targeting different treatment or different nutrient in the body, targeting different deficiencies in the body, aiming to improve the catabolic state, to improve anabolism, to restore any established deficiencies. In the cancer cachexia management, we aim to use any specialized nutrition support modality. We aim for using ONS, oral nutrition supplementation, enteral nutrition, parenteral nutrition, and immune modulating agents. And as mentioned earlier, in the refractory cachexia, those are patients who are not any longer under active cancer treatment, in which all different cancer treatment lines has failed. In those patients, we usually offer comfort-directed care, decreasing any negative consequences related to thirst or starvation.